I'm Dr. Mark Nestor. It's my excitement and pleasure to talk about an area with a lot of passion for me, which is superficial radiation therapy. I am current president of the American Cutaneous Oncology Society, and this is certainly one of the treatment options that we utilize for the treatment of non-melanoma skin cancer. So I'm going to talk about superficial radiation therapy, specifically comparing therapeutic radiation options, because it's very important as dermatologists for us to understand the differences between different forms of radiation therapy. Specifically, my disclosures for Census Healthcare, I'm a consultant. I've run advisory boards and a speaker for the company. So traditional treatments for non-melanoma skin cancer include excision, Mohs micrographic surgery, electrodesiccation, curettage, cryotherapy, some topicals, and actually superficial radiation therapy was the first therapy over 100 years ago that was used for the treatment of non-melanoma skin cancer. And it's been one of the primary treatments up until approximately 1970, where there was a loss of equipment and the real induction of Mohs micrographic surgery. But I think today, because of the change in dynamics in our patients, it's really time to revisit the use of non-melanoma skin cancer treatment with superficial radiation therapy. And there's some very significant benefits of superficial radiation therapy in the dermatology office. There's no need for radiation oncologists or radiation physicists. There are really very significant new technology and treatment paradigms, new computerized treatment systems for accuracy and safety. We know a lot more about fractionization methods to get the optimal results, and even the treatment of keloidal scars to prevent recurrence has been shown very clearly with the use of superficial radiation therapy. So guidelines for appropriate use are based on decades of research. And SRT in outpatient settings has been shown to be the least expensive and most effective form of radiation therapy treatment for the treatment of skin cancer. Dermatologists need to retain and refine the use for our patients. And more importantly, as I said, the elderly and infirm patients should continue to benefit from superficial radiation therapy in outpatient dermatologic settings. Additionally, there's a new consensus agreement and published, which is this, which we published last year on consensus guidelines, which very clearly outlines appropriate use for both non-melanoma skin cancer and keloidal scars. So let's look at radiation treatment modalities. So here are the most often talked about and used radiation treatment modalities: electron beam therapy, brachytherapy, and then superficial radiation therapy. And within superficial radiation therapy, over the last few years, people have talked about electronic brachytherapy, but as you'll see, this is really superficial radiation therapy in its inception. So what is electron beam? Electron beam is really a particle treatment, external direct radiation. What has been found is you need much higher energies for equal efficacy to superficial radiation therapy. And the maximum deposition is near the surface, but it also affects deeper tissues, so you get much more acute and latent effects. The equipment is very expensive, commonly a LINAC accelerator used by radiation oncologists. And as you'll see, there's lower cure rates and increased morbidity versus SRT. Now, it's important because they're particles, the pattern of ionization for electron beam is different, and it's more geared towards deep invasive tissue. The total doses are higher. And what's important is that there's something called the penumbra, which is the edge of the field. And the edge of the field really trails off at about 6 millimeters. So there's a large trail off. So you need to use higher energies and treat a larger area to get similar efficacy, but still you get lower efficacy and higher short and long-term AEs with SRT for primary non-melanoma skin cancer. And here's one of the studies by a radiation oncologist, Mendenthal, which essentially showed that superficial radiation therapy had a significantly higher cure rate than electron beam with both basal cell and squamous cell carcinoma. And here's another study by Lovett, which showed very similar results. with both basal cell and squamous cell carcinoma showing significantly higher cure rates with superficial radiation therapy. Now, in addition to that, because you don't have as much tissue destruction, you have better cosmesis. This has been shown, especially in areas such as the nose, paraoral, and paraorbital areas. And the most common side effect is some slight hypopigmentation and telangiectasies. Indeed, electron beam, there's significantly less favorable cosmesis, and you get alopecia, you get hyperpigmentation, and you get significant binding down of the skin with electron beam. Now, there are areas where electron beam is superior in the skin, and this really has to do with those tumors where we have to go much deeper. So tumors with perineural invasion, treatment of CTCL, Merkel cell, DFSP, and selected head and neck melanomas may be much better treated with electron beam therapy. So the second treatment that we'll talk about is brachytherapy. In brachytherapy, the radiation source is applied directly to the tumor itself, either a high HDR, which lasts just a few minutes, or LDR, which stays up to 24 hours. It is effective, it has local side effects. There's tremendous treatment restrictions because it's a bunker, and you need a radiation oncologist, and it's very expensive. More importantly, because you're placing the tumor, the radiation source in one specific spot in the tumor, this tends to work for very small tumors and larger, anywhere larger than about 1 to 2 centimeters. It really is much less effective because the radiation source is decreased over a short span of distance. So here is a study by Mirat Alam. It showed recurrence rates between 0 and 10% in ideal candidates, but lower cure rates are seen with non-melanoma skin cancer exceeding 2 millimeters in depth and greater than 2 centimeters in diameter. As I said, it requires expensive hardware and potential risk of exposure as well. Now, electronic brachytherapy has been a rage up until a couple of years ago. It uses an SRT source. It penetrates the top layer of skin, but it uses a miniature consumable non-isotopic 50 kV source. The applicator is up to 50 millimeters, and you have to collaborate with radiation oncologists and physicists. There's some long-term, excellent short-term cure rates, but few, if any, long-term studies. And this is an example of why this really is superficial radiation therapy. This is a Philips short contact SRT unit on the left, and on the right shows an electronic brachytherapy unit. So it is something that we see to be virtually the same. Now, superficial radiation therapy is low energy radiation which penetrates the top surface of the cell. It is deposited uniformly. Remember, I said that the penumbra for electron beam was 6 millimeters. Well, the penumbra, meaning the fall off on the sides for superficial, is less than 1 millimeter. So it really covers beautifully. So you don't need to overtreat both in terms of energy or size. It uses a non-consumable 100 kV source, applicators up to 180 millimeters, and it's most often used by far by dermatologists because of no need for radiation oncologists or physicists, and very high cure rates for both primary basal and squamous cell carcinoma. This is just giving an example of the different abilities to treat different sized tumors. Generally, we use between 50 and 100 kV. You get precise targeting, and the number of fractions seems to be optimized between 4 and 15 over 2 to 6 weeks. And the actual on time in the device is short, although the patients are certainly there longer. Now, the studies are very extensive on this. This is 600 patients with basal cells, 106 with squamous cells, 94 to 95% cure rates, 5-year for basal, and just about 93 for squamous cell. Recurrence rates were very small. Tumors with nasolabial fold and tumor size above 1 centimeter were increased independent predictors for recurrence. and it was shown to be safe and effective. One of the best studies was this from Armin Cognetta, which looked at 1,700 patients with basal and squamous cell carcinoma. Again, very, very high cure rates here, with recurrence rates between about 1% and 5%. The conclusion was that this was a viable non-surgical option for both squamous and basal cell carcinoma. Again, so much in the literature. This is pooled results of almost 5,000 patients for basal cell with well over 91% cure rate. Squamous cell carcinoma, similar, almost 94% cure rate for this large study of over 1,000 patients. Cosmesis for this has been shown to be excellent. This is from Cognetta's papers, showing no retraction of lip or ectropion, and most common effects are slight hypopigmentation, increased telangiectasias. Another paper from Cooper looked at cosmesis and was rated very good or excellent by patients over time. So what is my clinical experience with this? We look at a variety of different factors: patient age, medical status, comorbidities, anticoagulation, patient preference, which is important, the tumor type, recurrence, size, location, and other mitigating factors such as the patient needs. We adjust energies, margins, fractions, and the schedule to be appropriate for that patient. We are very important about patient safety with shielding and comfort. And there are very specific quality and regulatory compliance aspects, which are, for the most part, very easy to maintain. So we've treated well over 800 since in the last 8 or so years, almost 9 years that I've had this. We've had 4 recurrences to date with good to excellent cosmesis. The primary indications of this are basal and squamous on the scalp, lower legs, and nose. In my clinic, elderly with comorbidities, and we average about 15 fractions 2 to 3 times a week. So here are some clinical examples of the nasal ala here. This is the tip of the nose. There's another thing on the side of the nose. Nose, as I said, is really excellent for this because you don't see scarring with this virtually at all. On the scalp, and there's not a lot of room to move tissue on the scalp, so you can see the very nice result. And in fact, this completely wipes out any precancers in the areas treated as well. And the leg, the anterior tibial, is an area that's been shown to have a much higher rate of infection. You can see a very nice result here. And then you have patients like this with complex issues with large numbers of skin cancers. You can see here on the cheek, which the entire area was treated with a wonderful result. On the scalp, and again, you would have to do a skin graft here, but look at the wonderful result of this extensive basal cell carcinoma. And this is an elderly patient with a large squamous cell carcinoma. And the beauty here is treatment without surgery and no ectropion at all. So in conclusion, historically, radiation therapy has been one of the primary treatments for non-melanoma skin cancer by dermatologists, but it decreased over time and it's been delegated to radiation oncologists. Changing demographics, increasing non-melanoma skin cancer, and new innovations to equipment really should bring back SRT to dermatology. You understand now the benefits of SRT versus other forms of radiation therapy. There are some instances where electron beam is necessary and significant, and new fraction methods and therapeutic with a high therapeutic index and high cure rates with low acute and latent side effects, especially in difficult treatment areas such as the scalp and lower extremities, really make the treatment with superficial radiation therapy ideal for many of our patients. So I thank you for your time, and it's really been a pleasure.